All right. Hello, everyone, and thank you for coming. This evening, we have the privilege of hearing from Dr. Haworth about biomedical engineering in the COVID-19 pandemic. As you all should know from your reading last week, this pandemic has been a complex challenge to not only healthcare workers, but also to engineers and physical scientists. In the past year, several challenges for a more hygienic and safe environment have been proposed, such as self-sanitizing surfaces, new multifunctional custom PPE, and even incorporating antiviral molecules into masks where they could neutralize infectious droplets. Dr. Haworth went to Truman State University as an undergraduate student and received his Bachelor of Science degree in physics. He then went on to school at the University of Michigan and received a Master of Science and doctorate in physics as well. He eventually came to Cincinnati, where he performed his postdoctoral fellowship at UC. He is now an associate professor in the Division of Cardiovascular Health and Disease at the UC College of Medicine, and he also has a secondary faculty appointment within the Department of Pediatrics and Department of Biomedical Engineering. He teaches both undergraduate and graduate students and plays a vital role in our medical sciences program. Thank you so much for coming this evening, Dr. Haworth, and agreeing to lead us in a discussion about biomedical engineering in the COVID-19 pandemic. The floor is all yours.
Wonderful. Thank you. Thank you very much for the kind introduction, Rahul. If I can just get a confirmation, the slides come through okay?
Yep, we can see them.
All right, wonderful. All right, so I am, well, I'm going to talk about what Rahul said I'm going to talk about, so that's good. I am, as I'm going to go through this today, and for those of you that had me in class last semester, I'll know I do like to ask questions. So if I ask a question and I pause, it's because I'm waiting for somebody to say something. So be ready to unmute yourself, or kind of at a minimum, at least feel free to pop answers into the chat. I do have the chat window open on here, but when you've got the screen share on, it's not as easy to observe. So, all right, so let's go from there. So my primary goal that I want to convey to you is kind of with today's lecture is really an appreciation for what biomedical engineering has done and continues to do as we respond to the COVID-19 pandemic. And the approach that I want to take for doing that first is actually just talking about what is biomedical engineering and what is engineering. As many of you may have friends in the biomedical engineering program here at UC, you may have some idea of what it is. But I think it's important to really understand the differences, particularly between how biomedical engineers think and how physicians or clinicians are trained to think. From there, after we go through some of that, I'm going to talk a little bit about some examples of where biomedical engineering has come to play in the COVID-19 pandemic, particularly with respect to non-research roles. So what I really mean by this is, these are your biomedical engineers. They went to school for biomedical engineering. They've been trained that way, and they're now out in the workforce, doing good work. And so what are the things that they're doing, to help us all during this pandemic? And then from there, we'll transition and we'll talk a little bit about what are some of the ways that research is playing a role in in the pandemic. And we'll go through a couple of different examples. We'll have one somewhat extended example talking about transmission. That's going to be based off of that article that hopefully everybody had a chance to read ahead of time. And then we'll talk about the role that lung ultrasound can play. And that's got a spot near and dear to my heart because for anybody that knows me knows that I love ultrasound. So first, I want to start off by saying, how would you guys define biomedical engineering? And this is that cue to unmute or type something into the chat. And I'm really good with awkward silences, so I'll just let them sit there pregnant. I know you're all very smart. All right, there we go. We've got at least somebody. Hannah, thank you. So the design of technology that advances medical procedures. Okay. Excellent. Josie, making new devices or drugs to treat diseases. Certainly can fit into a definition of biomedical engineering. What about some more here? Advances in technology to advance medicine. Yep. So that's a big part of it. Any others? All right. Well, I'll assume you all warming up, and we'll get better responses on some of the next questions. But so I think those are some really good ideas from Hannah, Josie, and Arhama. The Whitaker Foundation defines biomedical engineering as a discipline that improves human health through cross-disciplinary research integrating engineering sciences with biomedical sciences in clinical practice. So I think that does certainly fit in with some of those suggestions that we had there. The Whitaker Foundation is actually a foundation that has provided the seed money for a number of different biomedical engineering departments to be established at universities across the country, including the biomedical engineering program here at UC. So in the early 2000s, they provided a pretty substantial grant that got the biomedical engineering department off the ground here. National Institutes of Health defines biomedical engineering as integrating physical, chemical, mathematical, and computer sciences using engineering principles to study biology, medicine, behavior, and health. So what we notice when we look at these definitions, and I think really we can also kind of see how technology and devices and drugs and stuff fit into them. But what we really see is, one is that this is a field that's going to combine other fields, right? So here we see physical, chemical, mathematical, and computational. Here they just talk about it being a cross-disciplinary area. So we're really going to be merging different areas, and in the process of merging them, we're going to use these quote-unquote engineering principles, or as the Whitaker Foundation calls it, engineering sciences, to do that. So let's get a little bit of an idea of what engineering principles are as we go through this. So unfortunately, there's not like a simple, clean answer to that question. And the reason for that is that engineering itself is an enormous field, right? In the same way, in medicine, you wouldn't say, what's a principle that, is going to apply to, your behavioral sciences and oncology and orthopedics, right? I mean, there are some common underlying themes there, right? But they're very different fields. In the same way, we've got here, even just at UC in the College of Engineering, we've got chemical engineering, mechanical engineering, electrical engineering, aerospace, civil, computer, biomedical engineering. Right? So each of these areas is going to have their own principles that they're going to work on. So while that doesn't necessarily lead us to being able to complete a very, very clean list that is all-encompassing and this is the one list and this is how we can define it by, there are certainly some common themes that we can have associated with this. So to better appreciate actually that perspective, though, let's actually start by thinking about how is a physician trained to think about problems? And physicians are really taught a categorical problem-solving approach, right? So our physician here, our clinician, really approaches problems kind of in the way of saying, I've seen something like this problem before, and this is how we dealt with it, and so this is what I'm going to do with this patient. Right, so as an example of that, perhaps we've got a patient that's displaying some sort of neurological issue, right? And that physician needs to take those neurologically related symptoms and figure out, okay, what's the underlying disease or pathology that's present here in order to decide what steps we should take in order to treat that patient. And that whole process is known as differential diagnosis, right? So they want to be able to tell, is this patient suffering from a stroke? Is it from epilepsy? Is it from a frontal lobe disorder? Is it something associated with a neurodegenerative disease such as Alzheimer's, et cetera, right? Now, how do they go about that, right? Well, they look at the patient, and what they're really doing is acquiring a lot of different types of data from that situation, right? So they may be taking imaging data or other data from some of the organs that are there, right? They may be taking cultures to see if there's an infectious disease, for instance, right? They may be gathering other information about the patient, such as height, weight, et cetera. Looking at things like medical history and prescription drugs that they're taking to see if there might be interactions there. They may even do some sort of biopsy or other sort of sampling of tissue to get a better idea. And of course, they're using all that training in the sciences that they acquired during medical school. So they're taking categories of information, or I should say, subsets of information, and they're trying to figure out then and say, okay, based on all this information I have, which of these different potential diagnoses is going to be the most likely case for what's addressing my patient, right? And so this is really known, again, as categorical problem solving, and this is fundamental to how physicians think about solving problems. Now, an engineer, on the other hand, is going to take either what's known as a reductionist or a first principles approach to solving problems. So what they're doing here is they're going to take their problem, they're going to define some sort of system, and we'll see two examples of this in just a moment, so it'll make some more sense. But they're going to define some sort of system, and they're going to talk about what are the core components that are present in this system as related to the problem at hand. And then they're going to say, okay, now that I have these core components, how do these core components necessarily interact with each other and also with the external environment? And how do I kind of put all that together to be able to solve this problem from first principles or from a basic approach, right? So rather than say, look at the anatomy and physiology of a patient and kind of integrate that all together, they're going to take this problem and figure out what are the core principles. So let's do this as an example for a case where an engineer is told, or just a person is told, to figure out how much water should an individual drink in a day, right? Now, somebody in the biomedical sciences might say, okay, well, I'm going to run a clinical trial. I'm going to give, this cohort of patients, they're going to have to drink 32 ounces of fluid a day. Another cohort's going to get 64. Another cohort's going to get 96. And I'm going to have a bunch of metrics that I'm going to measure in terms of, how they feel, how they act, what their mental acuity is, all these different things. And we're going to figure out, okay, which of these groups respond the best based on how much they're drinking. Right, so that would be a very biomedical sciences approach to it. An engineer, on the other hand, is going to say, well, I'm going to define a system, and that system, since we're talking about drinking water, that system is just going to be the body. And I'm going to think about the idea of homeostasis, right? This idea that, of course, the body kind of wants to stay at a stable equilibrium state. So the reason we have to drink water is because our body is constantly expelling water, right? And there's a variety of ways that water can be expelled, right? It could be through the skin, through sweating. Obviously, urination would be a large occurrence for where fluids would leave the body. Defecation would be another area where fluids could leave the body. Potentially respiration. So particularly, if a patient is in a dry environment and they continue to talk a lot, as I will do in this lecture, right? I'll have to take a drink of water to replace some of that. And so they'll say, okay, well, overall, we don't want the overall amount of water in this patient to change over the course of the day on average. And so however much goes out of each of these different locations is what the patient then needs to take in, right? And they can solve the problem that way. And in this case, the core components are looking at, which of these systems are most important. So let's say that they're solving this for somebody that lives in Canada and it's the winter. Well, there's probably not going to be a whole lot of sweating that's going on. And so they might say, well, sweating through the skin, that's not really a core component. And so I'm not going to include that in my model. But I am going to include, urination, and I'm going to develop a model for, how much one might urinate during the day. Or likewise for respiration. We know that the air that we breathe out is fully 100% humidified, but, in a dry environment in the winter, it might have very little humidity coming in. We know how much breath a person takes, how many breaths a individual has in a given amount of time. We know the tidal volume, or the amount of breath that's coming in and out with each breath, right? And we can then start to estimate how much water is lost that way. And so they can put all of these things together and build up a solution to this, right? And so that would be a first principles approach to trying to solve a problem with this. Now, it's not to say that, that approach is necessarily better than the biomedical scientists approach that we talked about earlier. They're just two different approaches to trying to solve a particular problem, right? Which one is better is a lot of times going to depend on what sort of data that you have access to and what type of solution you're looking for. So let's see another example of this, but let's do this in the context now of transmission of an infectious disease, such as a virus such as SARS-CoV-2. Right. So here we've got a figure. This should be a familiar figure to all of you based on the pre-reading that you did. So based on this figure, how do you see this figure, which is created by engineers, really demonstrating this idea of first principles approach to studying the transmission of a virus? Folks a minute, I'm supposed to type, but again, feel free to unmute yourself. I get very lonely when I only hear myself talking for an hour. I'm also assuming you guys find that as a funny joke and lots of people are laughing right now, even though it's silent. All right, so some hints here, right? Like I said, we'll let this drag on if we need to, but right. So obviously, some hints are going to have to do with the dashed lines that we see here.
Can you repeat the question? My audio cut out, so I didn't hear what you said.
Yeah, sure. Yeah, no. So the question at hand here is, so some engineers designed this particular schematic describing transmission of a virus, right? So we obviously have an individual with a virus here, and it's being potentially transmitted to this individual over here. How does this kind of schematic represent an engineer's kind of first principles approach to studying transmission of a virus?
I would say that this model here looks to identify all the ways that someone could get infected, whether that be airborne contact or through the fomites. Just like in how you showed us before, you could lose water in a variety of different ways. So that's how I imagine an engineer kind of was thinking and detailed this.
Yeah, no, I think that's a great way to do it, right? So when we talk again about this idea of first principles, here they've broken it down into the principle of we can have transmission through airborne, we can have transmission through direct contact, and we can have transmission through fomites. And then so the next step is to thinking about a solution on this, of course, would be, where can we create barriers here, right? And Josie points out in the chat there that, the lines are places of potential barriers that we can insert to be able to try to reduce that risk, right? So there's an approach to that, and then you're right on there, right? This whole thing we would define then as a system overall, right? So our system would be perhaps all these kind of routes of transmission here, right? So this is how we do that. Now, we've already Josie kind of already answered the next question that I have, which was, based on this figure, how do we see ways of reducing transmission? Well, anywhere we have a line here, right? So in this case, where would the impact of masks come from within this sort of a diagram here, in this way of thinking about this problem? Yep, so certainly step A. Yep, so that's right. Anywhere else? All right, so we've got E and possibly C. Yeah, so certainly I think E would be there, F and potentially D would be there. So kind of depending on how you're actually defining these things. So right, anything that's going to kind of block the barrier of the recipient space, particularly, we know that transmission through, the mucous membranes, the nose, the mouth, et cetera, the throat are going to be problematic. So putting a mask on right there, right, could certainly kind of block that contact approach, right, by just making it less likely for that individual to be touching their face. And of course, just the direct blockage of the virus-laden droplets that might be transmitted through airborne there. Yeah, so those would be different ways of doing that. Now, as we look at something like this, and we start to kind of think about this as an engineer, saying, okay, well, we can have a mask on this individual that kind of blocks things right here at A. We can have a mask on this individual, blocks things right around here in B. Does a mask need to be perfect in order for it to be effective? And by perfect, I mean, right, does it need to entirely prevent the transmission here? We've got a no from Josie. All right, no from Hannah, saying that, distance and other things can certainly play a role, which is true. Yeah, so it doesn't need to be. And the way that an engineer would kind of think about that is to say, well, let's suppose I was going to model this whole system, and I'm going to say that the mask that we have is only 60% effective, meaning that 40% of the viral particles that are emitted by the sick individual are still going to get out. And 40% of the particles incident on a given mask are going to make it through that mask or around that mask. Now you'd say offhand, well, that sounds actually pretty crappy, right? I mean, if 40% is going to get through. But if we take a very simple engineering model, and this is oversimplified, right? If we have 100% right here of the virons here, right? And 40% make it out, and they pass through here. Now, as Hannah pointed out, right, we might lose some along here, but let's say we don't, even a worst case scenario, we don't lose any of them. And we have 40% that's now incident on the face of this individual. But only 40% of that 40% is going to make it through, meaning that only 16% of the virus, viral particles that originally exited are actually potentially going to be incident on that individual trying to cause that, that may cause COVID-19. And as you probably have covered in some of your other lectures, right, viral load is going to correlate with disease severity that individuals are going to have potentially. And so even just having a mask that's only 60% effective can actually reduce that risk potentially by roughly 84%. So particularly, you know I saw a lot of these from, I'll just generously say naive friends and family early on that were, anti-mask folks. They'd show these, oh, look, this person's smoking and look at all the smoke come off the side of that. Well, yeah, that's true. That mask's not 100% effective, but that doesn't mean that it's not effective at all. And again, using kind of some simple modeling here, we can come up with that. We'll see a little bit more advanced version of this a little bit later on in the lecture. Now, in addition to engineers thinking about these problems from a first principles perspective, they also are going to include other approaches, right? So for instance, engineers are typically always going to try and use a scientific method as they think through problems. That's something that's different from physicians. Physicians don't often use the scientific method. Now, that's not to say physicians don't use evidence-based medicine, which certainly can be based on the scientific method, right? But a physician treating a single individual patient can't use the scientific method for a variety of reasons, right? In one part, they'd have to create a hypothesis and then design an experiment to test that hypothesis. Well, testing a hypothesis requires controls. We have a single patient, and you certainly don't want to treat your patient as a control. As you're doing that, right? You want to administer what you think is the most effective treatment. So really using the scientific method would be unethical in that case, right? That's direct application to scientific method. Again, they're going to use evidence-based medicine that scientists have come up with, that other scientists have worked their way through, potentially clinical scientists too. Right? Engineers are also going to be very solution-oriented. Right? This is what's going to differentiate them in many ways from, say, biologists, chemists, and physicists. Those individuals tend to be knowledge development oriented, where the engineer is really focused on what's the solution that we have in place here. A very common engineering principle that gets used across fields too is the KISS principle, keep it simple, stupid principle, right? The more complexity you have, the less likely it is that your solution is going to end up working. And then engineers often are incorporating mathematical modeling into their solutions. Okay. So I hope that gives you a little bit of an appreciation for kind of how engineers think about problems, because that's really going to influence the ways that engineers are then subsequently going to interact with a pandemic such as COVID-19. I just wanted to throw up this slide really quickly because this is very popular in the engineering field, right? The engineering flowchart, how do you solve your problem here? Again, breaking it down into, simple principles. Does it move? No. Should it move? No. Then you're fine. Should it move? Yes. WD-40. Does it move now? No. Then you're good. Yes. Well, go grab a hammer and whack it, right? And we've got the other side here with some wonderful duct tape to solve that, right? Whereas in medicine, it's keep calm and make your differential diagnosis. All right, so let's focus a little bit more now actually talking about engineering and COVID-19. So in this particular case, let's start off by talking about ventilators, right? We probably all remember from early on, ventilators were a huge issue. We saw all sorts of plots like the one that we have right here where there was an available number of ventilators that were present, and we were going to see these issues of having insufficient numbers of ventilators to treat patients that needed that oxygen supply, right? So ventilator demand really outstripped availability. And we saw then engineers play a role in kind of three different ways: design, construction, and maintenance of ventilators. On the design side of things, prior to the pandemic, we saw a lot of ventilators being built that were kind of these high cost, really fancy ventilators. They had all sorts of sensors built into them. They could work with the patient's respiratory motion, so they would detect small motions of respiration from the patient, and they would move in cycles that worked with that, and could do all sorts of kind of interesting and great things. The downside is, these instruments were expensive, they're hard to build, they're time consuming to build, they require a lot of maintenance because they have a lot of parts that are associated with them. And so in a case where you need just a lot of ventilators, this really isn't a great option to be using. Now, GE, who manufactures a bunch of ventilators, amongst other ones, said, okay, well, we can build simpler ventilators, right? Now, these are still powered ventilators. They don't have all the sensors and everything, but they work. They're easier to build. They're simpler to build, and we can get these out. But these still take a decent amount of time. And in certain patients, particularly perhaps severe patients, we need to use some of the bells and whistles that are associated with these sorts of things. But when we're thinking about, converting the Duke Energy Convention Center into a field hospital, right? Or, you're setting up MASH tents outside of a hospital for, hundreds of potential patients. Even this is not something that's going to be feasible because we might not even have such simple things as electric power, right? And right now we're talking about essentially the fact that we need to reconcile that what is normally a high resource medical environment, which is most medical environments in the United States, in some ways, when they're overwhelmed, become low resource environments. And so we need to think about low resource responses to that. And so engineers developed ventilators, don't have a lot of the functionality of some of the other ones, but they can at least function as ventilators. They don't require oxygen. They're very light. They're highly transportable. They don't require electricity. They still require oxygen. And so we need to develop these sorts of things. And so biomedical engineers really got onto the forefront in being able to design and very rapidly implement these sorts of things. Now, in addition to that, ventilators were built at facilities that were used to a pretty constant demand for their product. And so they built out without really considering speed and the efficacy with how quickly they could build it, right? So here's an example, a factory floor for a ventilator. You can tell this is, these are large ventilators. These are kind of fancy ones that are being built here, right? But this is not an environment that's well set up for being able to produce, hundreds or thousands of these ventilators in rapid succession, as was needed by some areas, particularly in New York there. So this is where, some of the pairing up that we heard, particularly with some of the automotive companies, came into play, right? Henry Ford in particular, right, is well known for being able to starting to build cars on these assembly lines rather than building individual cars. Something that happened a long time ago, but the auto industry has really maintained excellence in being able to do. And in converting then some of their plants, their facilities, their knowledge, and their workers, who may not have had expertise in medical device development, but certainly had expertise in how to assemble things, they were able to increase from a pre-COVID level of roughly the US, building about 700 ventilators a week, to getting into the thousands. This is obviously some data that was provided in early April. Being able to build them up and being able to provide thousands of them per week, right? So we're talking about a tenfold increase in production growth, which is really pretty remarkable when you're talking about a turnaround time of just a couple of months. Let's see, we got a question. How have these ventilators in mass production been efficiently sterilized during the pandemic? So that's going to depend in part on the production of them, Hannah. And that actually kind of leads nicely into the next slide that I have, which is, how do we maintain these things? And so there's the initial sterilization, right? So they're coming off a factory floor and they need to be sterilized. But then there's also the issue of, how do you maintain sterility as you go, say, from patient to patient in these kinds of environments? And that really depends. So some of that sterility is made by a lot of the tubing and things like that. Biomedical engineers recognizing, these are going to be hard things to do. And so they're hard things to sterilize, but they're very easy to manufacture, right? And so we're just going to make a bunch of tubes and we're going to be able to sterilize them at the manufacturing facilities and send them sterilized. And things like ethylene oxide gases are a very common way of sterilizing a lot of medical devices, right? So this is a gas that, the plastic, the metals, those sorts of things are very robust against this gas, but really would degrade, bacterial viruses and other contaminants that we'd be concerned about. Other surfaces, though, need to be manufactured with ideals in mind of, what are the types of things that we can use to wipe them down or apply to them in order to sterilize them. And these are the kinds of things that, the engineers that work at UC Health are needing to consider and implement during these processes. In addition to that, particularly when you have these ventilators in such high demand and high use, we need to make sure that maintenance, right, their function is both accurate, right, they're well calibrated. Even the simple ones, you're still going to set a dial so that, there's a certain amount of tidal volume per breath that's being done there, right? They need to be checked. They need to be ensured that they're accurate over time. And when they break, right, you need somebody to repair these things, right? And these are all roles that engineers are going to play in the COVID, or have been playing in the COVID pandemic. Now, another place where engineers have been very helpful is we talked a little bit about this with the example in Ford, but is actually rapidly increasing the production rates of these things. And a lot of that happened through conversion of existing manufacturing facilities. So you may have heard about Honeywell converting one of their aerospace factories into a mask factory. So they did this in the order of just a couple of months, and they increased, they were already producing N95 masks as a company, but pre-pandemic, they were only producing about 20,000 masks per month. Using engineers to convert their facilities, they were able to ramp up from 20,000 masks per month over the course of just I think about 3 months to making 20 million masks per month, right? So over a 1,000-fold increase in production rates. And all of this wouldn't have been possible unless you had the engineers that were kind of behind these facilities working on this. I will say, actually, my wife works for Honeywell, not in this kind of mask space or anything like that. She's on the finance side. But I was able to kind of get some inside information that was going through. These are very non-trivial problems to try to do to be able to convert things as rapidly as they did. Really a really impressive feat for the engineers that did this. Now, the last example I want to provide kind of on this day-to-day thing is through the Internet of Things, right? So IoT, if you've heard of this, right? This is the idea that more and more of our devices are being found and are available on the internet, right? And it's engineers that really facilitate the production and the interconnectedness of all of these devices. And this has really become even more important during the pandemic, right? So we may have ventilators that are present there. We have various monitoring devices that are going to be available and they're going to be present on our patient. And there's a lot of value. It's not just like electronic health records. Oh, that's great. We don't have paper. Yay, we're saving trees, sort of thing, right? This is much more important than that, right? This is taking this information, being able to port it over to the nurse's station, so that nurse doesn't necessarily have to expose herself as often to that COVID patient, right? So we're protecting the healthcare worker from that. We've just finished talking about how PPE, particularly early on in the pandemic, and even now still in certain occasions, is limited, and we need to take care of that, right? So if you can monitor this patient remotely, you're also reserving PPE so it can be used more efficiently and more effectively. And then, of course, telehealth has exploded during the pandemic, right? And this is not just for COVID patients, but really all of us, right? I don't know how many of you have gotten sick or had something, un-COVID related, where you've then called in and been able to talk to a physician, for instance, and get feedback, right, in a way that isn't possible otherwise, right? And again, a lot of these things, this is engineers that are behind the implementation of all of these things. Now, whether these individuals would call themselves biomedical engineers or computer engineers or some other type of engineers, is really a matter of semantics. The core is that these are individuals that kind of think from these engineering perspectives and are solving problems in these sorts of manners. All right. Any questions now before we hop on to talking about some research aspects for COVID-19? All right, so hearing none, and again, feel free to type into the chat there. I do have it up. Let's talk about some research examples of this. Recalling that, when we talk about these problems, BME is this integration, as the NIH defined it, of physical, chemical, mathematical, and computational sciences using these engineering principles to study biology, medicine, behavior, and health. So again, what we're really talking about here is these engineers are solving some of the very same problems that biomedical scientists, clinician scientists are also trying to solve. And they're just going to use a different approach. And it's not to say that the engineer's approach or the clinician's approach or the biomedical scientist's approach is better. It's a matter of, we want to throw a bunch of darts at this because we don't know which one is going to stick, right? You've probably all, at least through the College of Medicine, gotten some exposure to the idea that most translational research fails, right? 95% of translational research fails in the sense of translating into the clinic. Now, it may produce knowledge, which is great, but it fails to translate. And so if we want things to translate, we need to throw kind of a diverse set of perspectives at these different types of problems. So let's go back to the transmission problem. We saw that example from the first figure in the pre-reading. And let's look at how two engineers, Dubuque and Drakakis, tried to solve this engineering problem. And they were approaching it from a theoretical perspective, right? So they wanted to say, okay, we want to model how this transmission is going to occur. Well, if the transmission is occurring via viral-laden droplets, first thing we need to know is, what are these droplets? What do they look like? And so they went back in the literature and they found some data from Shi et al. That looked at, what are the size of droplets and how many of those droplets do you have when an individual starts coughing? Right, so that was the data right here. They went ahead, Dubuque and Drakakis said, okay, well, let's fit this to a model so that we have a theoretical distribution of these droplets here, and that's going to make it easier to apply our mathematical models. Once they had the model for, right, so there's going back to these first principles, right? So now they've got first principles on the droplet. Now the next thing is, let's go first principles. How does that droplet interact with a potential mask or a filter within a mask? Right, that droplet might stick to the mask, it might bounce off the mask and splash, it might penetrate through the mask, potentially breaking up into smaller droplets. And they developed mathematical models to try to explain both the probability of any of these three things occurring and also what was going to happen as a result of that. Right? In particular, things like this result in a very different outcome than, say, a rebound where the droplet then goes back towards that patient, if we're assuming that the person is sneezing from the left side of the filter right here. Then on top of that, they said, okay, well, we can treat air as a fluid. So you'll notice this is from a journal called Physics of Fluids. We can treat air as a fluid, and if somebody is breathing or coughing through their mask, we can actually look at what are the air particles doing and how are they moving and at what velocities are they moving as someone coughs from that mask, particularly in this case, a surgical mask, right, where there are gaps around it. And then they can take and say, okay, we know how large our droplets are based on their composition, their density. We know how quickly they should fall due to gravity. We know from this sort of information what sorts of convection forces they're going to feel on this in terms of, then how far are they going to move? And then how many are even going to make it past the mask using this modeling right here? So again, they've taken these kind of different sets of first principles, combined them together, and then they can create these kinds of models where as a function of time, they can look and say, what are these droplets doing? So in the top row here, we have an individual that's coughing, has droplets expelled, and they're not wearing a mask. The bottom row right here would be the similar individual, but they're masked. Right? They kind of plug in all of that information that they had before. And first, of course, it gives us the very obvious result, right? It gives us this obvious result that, of course, if you're not wearing a mask, those droplets are going to translate much further than if you are wearing a mask. And you might say, okay, well, that's a lot of work to tell you something that's pretty obvious. Well, one thing that's useful about this, right, is we actually get an idea of what is the distance, right? We hear about this 6-foot distance that's there, right? Based on their model, they actually indicated 6 feet might be an overkill depending on the droplet size, at least at the time frames that we're talking about here, right? So this is 4 seconds and 5 seconds after that. One of the things that I thought was particularly interesting, though, about their work was as they looked at the spread of the droplets, what you can actually notice is if you look laterally, right, to the sides of the patient, you actually have more droplets in the case of the mask than you do in the case without the mask, right? And again, maybe as you start to think about that, that becomes more intuitive because you've got perhaps more gaps on the side of the mask for those droplets to be expelled from. But that's maybe not something that intuitively would come to mind. And this may have some, some impact on what you would say about, in terms of keeping social distancing. It might be that, you're in a lab space or, a clinical space, and you think, okay, well, I don't want to face that person because I'm used to, as I breathe out, right, the air is coming straight forward and out of my mouth. And so I'm going to stand off to the side of the person to have a conversation. Well, this sort of data would indicate that's actually probably not maybe the best move to do, or at least, to do and feel comfortable standing closer to that patient. This type of data also can be useful because it can also help us figure out, well, what can we do to improve mask wearing, for instance? And so there's some really cool work that's being done on, how do we improve masks? And some of this is actually getting done at UC here. And I just sent the student course leaders for this. I just sent the slides to, so you'll have them later. But there's actually a URL for a news article here for a couple of engineering students at UC that said, let's try to address some of these problems associated with the fit of a mask, both how comfortable it is, but then also, how well it's going to block particulate that's coming out of there. And what they did is they said, well, let's develop an app that can be on your phone. You can actually scan your face. So if you've got like Face ID or, some equivalent thing, right, where you kind of rotate your head and it scans your face. They designed an app that would do that, would scan an individual's face and convert and create a 3D model of that individual's face. From that 3D model, they can then automate the production of, what is the curvature and the dimensions and the geometry of this. So we could then design a mask that would be custom fit to that individual's face. Now, on top of that, they said, well, let's use the fact that we can 3D print things to build custom masks fairly cheaply and fairly easily. And this is actually, these are 3D printers from I believe I can't remember if it's the Stucco lab or the Young lab over in engineering. But they actually then started printing and created these custom-made 3D printed masks that, they could actually pop onto the patient. So as you look at this, right, this seems like this should have some value that's associated with it, right? We're going to have value that's going to come from hopefully reduced transmission. We're going to hopefully have value that comes from increased comfort and fit that's associated with it. But we might also have limitations associated with this mask, right? How does this mask work as the patient talks, for instance, right? The geometry of the face changes as an individual talks, right? And that might then, factor into what sorts of materials should we use for a mask like this, right? These are all very much engineering problems that we can be tackled and are being tackled by individuals at these points. Now, speaking of material properties, right, we can look at this this fact that some of these particles are going to be making it through the mask, and we can think about, well, can we reduce the exit of those particles by changing some of the material properties? And if we go back to that pre-reading article that you have, right, it talked about these respiratory droplets that are laden with, lipids and proteins and, of course, the viruses themselves. Well, they're in this aqueous media, and we can use that then for inspiration in engineering then improved masks. And when we talk about these three-layer, tri-layer surgical masks, that's really how these things have been designed. They've looked at, from engineering principles, how do we improve this? Well, if we are exhaling in this direction and inhaling in this direction, right? So this would be closest to the face. This side would be closest to the mouth and this side would be away. If we're trying to prevent, if we're using the surgical mask for the primary purposes of protecting the individual that's wearing the mask as opposed to protecting others, right? The first thing that you want to do is say, well, let's create a somewhat hydrophobic layer that's going to be resistant to those particles, and it's going to make it more likely for those particles not just to get caught on the mask, but actually more importantly to actually be repelled by that mask, so that they're not, it's much less likely if that person then happens to touch their mask that they're going to get virus on their hand. Now, knowing that that's not going to be perfect, right, we can design another layer, right? This would maybe be like a filtration layer, and so here you're talking about weaving your fabrics at a fine enough rate and perhaps having electrostatic components on them in order to try to trap various particles or pathogens that would be located in there. And then finally, including an absorbent layer, right? And this is really meant to absorb the exhaled breath that comes from here. So this layer isn't so much directly preventing the virus from making its way into the patient, but instead what it's really meant to do is prevent the soiling of these outer layers by the humidity and the breathing and the coughing from the wearer of it. Right? And so again, this is ways that we can use engineering to design these things and improve them. Now, that all really focuses on transmission and research that's being done on improving materials and improving mask design from the airborne transmission route. Right? But we also talked about that you can have transmission routes through direct contact and through fomites, right? And fomites is just kind of the fancy term for these particles that'll settle onto a surface that we might then subsequently touch and transfer to ourselves. So Dr. Van Dormelen, who's with the NIH and is a virologist and does some engineering work, had actually previously, back in 2013, looked at how does the SARS-CoV-1 virus survive on different surfaces. She then, in 2020, as soon as the SARS-CoV-2 virus was identified, immediately repeated her studies with these. And what I want to point out is, this was a New England Journal of Medicine article from April 2020, right? So this is, extremely quickly done research that's occurring here. And the idea being that she took these 5 microliter droplets, right? So trying to mimic the size droplets that you might have with coughing. Now this is virus in cell culture media, placing it on these different surfaces, so copper, cardboard, stainless steel, and plastic, and looking at how long do these viruses last. And one particular metric that she used was looking at half-life, right? So how long until half of the virus, viral particles die over the course of wearing that? And, some of the results were not too surprising. So for instance, on plastics, they last a long time. On copper, which is known to have antibiotic, antiviral properties, they don't last very long at all. It was pretty interesting to find out that stainless steel, they actually last for quite some time, and cardboard, they actually don't last for as long as the time on stainless steel. Now, even though this might be the case and they don't last as long on cardboard, why would we not want to use a lot of cardboard surfaces in an environment where you have a lot of the SARS-CoV-2 virus? Any thoughts? Why would, even though virus can last longer on stainless steel, why would it be advantageous to use stainless steel as opposed to cardboard? All right, so stainless steel lasts longer, so that's certainly is true. Yeah, and Justin, yeah, that's a great point right there, right? So another important thing is that you're going to have particles are going to get trapped onto the cardboard, so they may not last very long, but it's going to be really hard to disinfect that cardboard surface, whereas stainless steel is something that you could rapidly disinfect as you're going through, and so that's a major advantage to that. So Hannah asked if I could explain why copper has antiviral properties. That's actually outside of my knowledge realm, Hannah. So unfortunately, I cannot answer that question for you. But I do know that there is work out there on both the use of copper and silver, which both have antiviral properties. But I don't know the biological mechanism by which those things interact. Now, this is kind of a really influential article when it first came out, but one of the things that was kind of important about it was kind of utilizing, this idea of, can we have self-sanitizing surfaces, right? So if we start impregnating, say, copper on a lot of the surfaces in a COVID ward, would that be highly advantageous? And this is where the idea of going to first principles in engineering can actually result in some limitations. So in this particular case, she went to first principles and said, let's just do something simple, virus and culture media, right? But that's not actually where viruses are transmitted, right? They're actually transmitted in these droplets that have all sorts of different components that are located within them. And the question is, a virus that's now in this this environment that's going to have a lot of different layers around it that may actually serve as a protective coating, are you going to get the same sort of effects on copper? And so this is where sometimes then the complexity needs to be advanced on. Nonetheless, some really impressive and important work that Dr. Van Dormelen did, extremely quickly in this whole process. The last example that I want to give you with regards to some of the research that's going on is just one example of things that's unassociated with transmission and transfection, because we've been very highly focused on that. And that's some of the work that Professor Elizabeth Wayne, who's a biomedical engineer at Carnegie Mellon, is doing. So her lab was actually studying activation of monocytes and macrophages using engineering principles prior to the pandemic. What she noticed very early on in some of the earliest articles was that COVID patients were showing increased levels of monocyte activation, and also the individuals that were most susceptible to the disease, at highest risk, such as those with diabetes, also tended to have high monocyte activation pre-infection. And so this obviously got her thinking, well, perhaps we can use some of the techniques in my lab that combine, techniques in immunology and virology with biomedical engineering principles to be able to study this problem. And so she was able to get a grant funded through the National Science Foundation that's looking at, as the SARS-CoV-2 virus enters monocytes, how does it react intracellularly, and analyzing that not from a biological pathways perspective, but actually using engineering principles and engineering mathematical models in order to predict how it's interacting and why we're seeing upregulation of these activation of these monocytes. Her work, which was just awarded in the last several months, is still ongoing, and should be some really exciting work that's going to come out of that, or results published in the near future. All right. I want to take the last couple of minutes to talk about one last example, which is lung ultrasound. So I've already mentioned I teach the medical imaging course, so if you happen to like this last section here, you might consider signing up for the medical imaging course. Also, a number of individuals on the call here. I saw Arhama and Justin and Suchi and a variety of others took the course, so you can always ask them how painful it is or how enjoyable it is. All right, but why would we want to talk about ultrasound in the context of COVID? Well, first, it's important to understand what ultrasound is and why ultrasound is such a valuable diagnostic tool. So the first is ultrasound is the most portable medical imaging modality. So this is the butterfly transducer. It was designed in just the last couple of years. What's amazing about this particular transducer is it literally plugs into an iPhone and turns your iPhone into an ultrasound scanner, right? So, this is as portable, if not more portable, than a stethoscope would be. Now, in addition to being portable, which is obviously very important when you're dealing with infectious patients, right, that you don't necessarily want to be transporting across the hospital, if at all possible, to, say, a CT scanner or an MRI scanner, is that these are also real-time images. So unlike, again, MRI, CT, et cetera, we're going to have to take the patient there, you get the scan, you got to wait 15 minutes, 30 minutes, however long it is in order to get that image to make your diagnosis. You can actually do point-of-care ultrasound where you actually make the diagnosis while they're with the patient, looking at the patient, right? If something doesn't come through well on the image, right, you can stand there and you can adjust things until you get what you need. Now, how is this going to be useful for COVID? So in order to understand, we need a very quick and brief introduction for how ultrasound works. So the idea is that an ultrasound transducer, so that's this gray thing here, is pressed up against the skin. So here we have some skin here. An ultrasound wave is sent out, and it's a mechanical wave, propagates into the body, and it reflects off of parts of the body where there's differences, right? So interfaces within the body. Some of that mechanical wave is going to reflect back up and go back up towards the transducer, and some of it's going to continue propagating down. Right, so some of it goes back up to the transducer detects that signal, and we pick up some signal here. The rest of it propagates forward, say hits something else in the body. That's going to continue to propagate up while nothing's hitting it. We get no signal, and then it finally hits the transducer, and we get another pulse there. We convert this signal as a function of time into kind of this grayscale sets of values that look like this, And then using the fact that space and time are related by the speed of sound of something, right? So how fast that wave is traveling, this thing that arrives as a function of time can get converted into how far away are these things that are there, and we can create, say, a single line of an ultrasound image where we know that there's a scatterer here and there's a scatterer here. We basically build up a bunch of these different lines, and that's how we form an ultrasound image. Now, when we form an ultrasound image of the lung, so here we have an ultrasound image, you're going to send ultrasound out of the transducer, and it's going to have basically fluid type tissue, right? That's going to be located here, so muscle, fat, those sorts of things. And then you're going to have the interface of the lung, which is located right here. These are meant to be the ribs right here. The lung is predominantly gaseous, right? Because of the alveolar sacs. And so you're going to get a change in what are known as acoustic properties, and you're going to get a reflection off of that. So the ultrasound is going to come in, it's going to bounce back to the transducer, and we're going to get it. That's going to form kind of this bright line that you kind of see, kind of a little hard to see here, but that's going along right here. Now, it turns out because you're close to the lung, and the lung is such a strong reflector, and the transducer itself is a strong reflector, the ultrasound that came to the transducer, some of it's going to bounce off the transducer, back off the lung, and come back up. And that's going to give you another bright line right here. Now, this is considered an artifact in the image because it's not something that's real in the tissue. There's nothing at this depth in the tissue. It's just that you're seeing this interface, this lung tissue interface, a second time, and then you can get a third reverberation, a fourth reverberation, etc. Now, again, these are artifacts because they don't represent something that's actually physically at these locations in the body, but even though they're errors in imaging, physicians and engineers can recognize what they are, and they can actually use that for diagnostic value. So in this particular case, this indicates that you have a nice, smooth, healthy lung surface, and this is what you want to have in a healthy patient. Now, in a patient that is sick and particularly has, an infectious disease in the lung, you typically are going to get interstitial fluids that are going to build up between the alveolar sacs, and so that's these kind of little drops of, that are shown right here. Now, ultrasound will then propagate through that liquid, and you're going to then have ultrasound propagating further into the tissue. And so you're going to get these kind of bright up lines that are going to travel vertically in the image. These are known as B lines. They're, again, also an artifact, but they're an artifact that only occurs when we know that we have interstitial fluid that's occurring in the lungs. And so we know that we've got a denigration or a decrease in the health of the lungs that are present there. Now, if you get all the way to the stage of, say, pneumonia, where you're actually getting mucus that's forming in the lungs, that mucus, it acts like a soft tissue, and you get a total breakdown of that kind of nice pleural line that you had there, that boundary between the tissue, and you see what's known as consolidation. It shows kind of this dropout and this darkness right here. Furthermore, you're going to get a consolidation of a bunch of B lines, and they call them C lines, C for just consolidated B lines. And B just means that it's a bright line. They're very creative in their naming schemes here, right? And this tells you what's going on right here. Now, the reason that all of this is important is that as this happens in the lung, as this ultrasound image changes, that correlates with the ability for the lung to be aerated, right? And the whole point of the lung is to aerate and to oxygenate the blood and remove the CO2, but that's not happening if you have these sorts of things. And so you can really start to diagnose the quality of the patient's lung health and how likely they are to need, be okay to, say, send home for recovery versus needing to be admitted, monitored, and potentially put onto a ventilator. Now, engineers, and I know we're at time here, so I'm gonna not cover this in as much detail as I'd like to, but engineers actually then developed a whole scoring scheme based on these images and the occurrence of B lines and consolidated B lines and C lines that are observed here, and developed these scoring systems, developed ways of then looking at different locations on the patient, combining those scoring schemes together in order to develop protocols to say, when should we send a patient home to recover versus when should we admit a patient, right? And this is really useful for a number of things. So one, obviously, is it's useful for prognosis, right? At the beginning of the pandemic, this was also quite useful because we didn't know if patients had COVID or not. And this is one way of at least not specifically knowing they had COVID, but at least knowing that they had an infectious disease of the lungs that was responsible for some of the symptoms that they were doing, helping out with that differential diagnosis. They also were able to then, as we've already talked about, use that for triage of patients. And then finally, even as the pandemic has gone on, and particularly at the peak of the pandemic, where they started to assume everybody that came in that, say, had shortness of breath and fever was a COVID positive patient, well, just because that patient then, say, on a pulse ox might be hypoxic, we don't know if they're hypoxic just because of lung issues, which might necessitate a certain type of treatment. Or, for instance, this just happens to be a patient whose symptoms, heart failure symptoms, are being exacerbated, and they're hypoxic because their lung is not working well. That was actually a really important discovery because there were a lot of patients that were being treated for lung-related issues when they tested positive for COVID, when in reality what they needed to be seeing was not the pulmonologist, but the cardiologist as they went through on that. So just as kind of some key takeaways from this lecture here, right? First is that, engineers and physicians are really trained to think differently. Clinicians really think from a categorical problem-solving approach versus engineers thinking from first principles. And I think one of the reasons I love being in the College of Medicine as somebody that's trained in engineering and physics is that I get to work with people that think differently from me, and we get to really come up with creative solutions by putting together these different types of thought processes and thinking approaches. The second is BME has played a huge role in kind of just maintaining and responding as a society, as a country, as a world to this crisis, right? In terms of maintaining PPE supply, ensuring we have adequate equipment, and doing those sorts of things. And that's not even to get into, of course, a lot of the diagnostic work also involved engineers in terms of microfluidic systems and microfluidic chips for rapid testing and things of that nature. And then, of course, we talked about different ways that research is involved, including, transfection and improving PPE, understanding how COVID-19 works, and developing, scoring schemes like those that I just talked about that help with triaging patients. And with that, I will end the lecture, apologizing for going a couple of minutes over, and be happy to answer any questions that you guys may have.
Thank you so much, Dr. Haworth. Does anybody have any last-minute questions?
So Hannah asks, can B-lines indicate the severity of edema? Yeah, so that's an excellent question. I would say that's an active research question that's still going on, and applicable, obviously, not just to COVID, but really, any respiratory disease. The data, I would say the data that I've seen at this point indicates that there is certainly qualitative correlation with severity of edema in the sense that, you could kind of, if you want to stage patients and you want to stage the level of edema, they're at that point and it can be used for that. To do it more quantitatively is, I think, where things are at actively right now. And actually, one of the areas that I didn't get a chance to talk about at all is the role biomedical engineers play with artificial intelligence, deep learning, machine learning, all those sorts of things. And actually, that's a huge area that's getting used right now, where they're using machine learning in order to not just identify B lines, but characterize the B lines in order to improve that diagnosis of severity of edema. So yeah, great question, and definitely an area of work there. Rishi, has there been much literature on the use of ultrasound as a potential treatment modality for COVID? In terms of treatment, no. You may have seen just in the last couple of days, there was an article that came out at MIT talking about the use of ultrasound to actually destroy the COVID virus. So there was a group at MIT that did some modeling of very high frequency ultrasound. A lot of the articles are talking about it being medical diagnostic ultrasound. It's really above the range that is commonly seen in anything except for maybe dermatological applications. But they were looking at 25 to say 100 megahertz, and they were modeling it, and they were seeing that the pressure waves at certain pressures were sufficient to actually cause the virus to collapse in on itself, and for some of those spike proteins to actually break off. And so there's some, again, this is a purely theoretical work. So there is now a standing hypothesis that perhaps it could be used to actually destroy the virus itself. The challenge there, at least in terms of treating patients, is that a lot of the virus is in the lungs, and lung ultrasound just doesn't propagate very well into it. The only time it does is when you have things like edema, interstitial fluids, mucus, and that sorts of things. And so you're probably not going to get a very uniform treatment of the tissue. And then, of course, there's a question of if it's doing that to the virus, what are the impact on, say, the nucleus of cells and things of that nature? And that's really just totally unexplored at this point. Great question.
All right, well, seeing no more questions, thank you so much, Dr. Haworth, for coming to present to us. It's been amazing. And students, we'll see you next week at the same time.
Well, have a great evening, everybody. My pleasure. Thanks all. Thank you.